Good morning, everyone. I hope everyone can hear us okay. I want to thank everybody for joining in today. This is a great, wonderful event that everybody has worked really hard to put together. And today we're going to talk about a hyperbaric safety drill and that we're recommending and stuff that you guys are going to benefit to go over. And we hope you pick up some really good tips. So we're going to talk about our door lock and our cam pin failure. Our hyperbaric unit is Unity Point Health Des Moines, Iowa Methodist Medical Center, and I am Deb Kritz. I'm the clinical team leader, safety director of our department, and I'm Mindy Sherdahl, the other hyperbaric nurse. So when you look at our picture in the chamber right now, this is taken in 2019, where close contact with team members was allowed. So this one obviously is COVID-19 2020 picture. How we're having to don glove, mask. We don't have gowns and gloves on in this picture, but you know, this is our picture. So we have no identified conflicts of interest to be disclosed. Our objectives that we are going to discuss today is discuss built-in safety features related to our chamber door operation and discuss interventions related to mechanical and pneumatic failure of the door lock pin and discuss recommended weekly safety checks related to the locking cam. We want to make sure that we start off this presentation by giving everybody recommendations that all hyperbaric units should have a safety kit. And it's like in that safety kit should include a solid object to check the locking pin, a screwdriver, an Allen wrench, an IV pass-through, scissors, and a 7/8 inch open-end wrench. And we'll be discussing some of the items in our little safety kit as we move forward with this. So when we look at our locking pin, and we look at basically looking at all the safety features of the Perry Sigma 40 chamber. Our locking pin automatically activates with pressure of greater than 1 psi. This doesn't allow the door to open. Our door interlock, if you don't have the door completely closed, that does not allow the pressurization of the chamber. So when we look at our weekly safety checks, part of our weekly safety checks is that we pressurize the chamber to 3 psig. And then what we do is once we get the pressure to 3 psi, then we insert our IV pass-through into that opening that you can see in the picture. And you should meet resistance, and you should be able to push in and build back pressure. If you don't, then potentially your weekly safety check for that locking pin, there may be something wrong with that. So you should investigate that further. So what do you do if the automatic door lock does not retract at 0 pressure? So if the pin does not retract, the door doesn't open. You attempt to mechanically retract the door pin lock by inserting a solid round object, again into the hole, as seen on the picture. You're attempting to push that pin free of the shaft so that you can open up the door. Well, that doesn't work. So then you go back to, okay, this is probably a pneumatic problem. And the pneumatic problem basically is that you push the pin back, and when you push that pin back, it hasn't worked. So then what you're going to do is you're going to cut or pull off that plastic tubing. We use a scissors and we cut that little tubing right where it shows on that upper picture by that arrow, because it's important that you cut it as close to that insertion site as possible. So the door still doesn't open. So then you move to the next step, which is a mechanical problem. So you take your 7/8 inch open-end wrench and you're going to loosen the cylinder lock nuts. You're going to unscrew the pneumatic cylinder from the shaft, and now your door hopefully will open. So that's that part.
So now I'm going to tell you just a little bit about what happened here at our hyperbaric unit. I had a patient in the chamber, and it was well, fortunately, unfortunately, his first treatment, and everything went as planned and normal. I decompressed him just as normal. And at the end of the treatment, I pushed exhaust bypass several times to make sure the chamber was purged. And I went to open the door, and the door did not open. The door would not budge at all. It was definitely stuck. And first thing, I went back and I made sure that I had pushed exhaust bypass and the gauges were at 0. I thought maybe I had done something wrong, so I pushed it again, and the gauges were at 0. The chamber had been purged, and so the door should have opened, but it still would not. Luckily for me, my safety director was right on the other side of the privacy curtain, and so I very calmly said, Deb, the door won't open. And so she came over to assist me. She again checked to make sure the gauges were at 0, tried to push exhaust bypass, tried to open the door, and the door would not open. We did skip a step here. We did not check the locking pin. We could have inserted our IV pass-through in the pin to see if we could get it to open that way. But we were both thinking about just getting the patient out of the chamber. So we took scissors and we cut that plastic tubing as close as we could to the bottom of the cam.
To everyone's safety during the COVID-19 situation, we are no longer allowing visitors to the hospital.
We have a little announcement right now for our COVID-19 no visitors. I will resume in just a minute because I'm sure you can't hear me.
COVID-19 situation, we are no longer allowing visitors to the hospital. Please refer to our sign. Thank you for helping keep everyone safe.
We are very safe here, and that's what we're talking about. So we cut the tubing, and as soon as we cut the tubing, we did a little small tiny twist, and the door opened just fine. And the patient had no idea what had happened because it was his first treatment, so he thought that this is just how long it took to get out. And really, we worked very swiftly and got him out right away.
So if that happens, you guys, I think what's more important is that, you know, everybody needs to notify safety director what happens. If there's anything that goes on with the chamber, obviously you're going to notify the people that are involved with it, all the safety of the hyperbaric unit. Notify your medical director, and you know that chamber will be completely out of service. You know, we called Cherry their medical services, and they instructed us to tell them what to do. You know, that chamber out of service until their medical reviewing with us all the safety aspects, and then they come out and did their annual maintenance, and then we can back in operation. I think it's important for everybody to review their monoplace operations and maintenance manual, and really just read that annually, because there's always little things in there that you can pick up on or you may have missed. So it's important to make sure you do that in all your safety drills. So in the conclusion here, obviously our patient got out safely, and you know, we reviewed our manual, we reviewed and we did more safety drills, and we pulled together our safety kit so that everything was put together. So questions, will be taking questions at the end of this lecture.
And now Anthony is going to discuss the little differences in a C-cuff chamber, and then also discuss how to design an interactive safety drill, and then we'll be available for questions.
Okay, so that's the end of mine and Deb's part. So if Anthony can take over.
Thank you too. That was a lot of work, and you made my claustrophobia anxiety kind of rise just a little bit there, thinking about that.
Yeah,
thanks for sharing.
Don't worry, if you cut that tubing, you can open the door real quick.
Okay,
right.
Everyone can see my screen?
Yes, we can.
All right, so my name is Anthony. I have been a hyperbaric nurse for 20 years now, and Deb actually taught me everything that I knew when I first started 20 years ago. I am the safety officer. We don't say safety director because that implies a layer of administration that I do not possess. The only thing I need to disclose is that my employer, UC Health, provided me resources, although they are not receiving any additional financial reimbursement from this, or nor am I. So the Seacrest chamber is slightly different in that the bottom corner here lines up slightly different, and you can see clear through to where the pin extends into the chamber. And there are tubes that come to a valve here, so there's a little bit more complex mechanism that operates this three-way valve inside the chamber. The chamber will extend that pin in as it's pressurizing over about 7 seconds, and it doesn't extend actually very deep into this long tunnel. And at the end of the treatment, it will retract back in if everything's working properly, and it will do so prior to the wink light going completely to black. So with this particular manufacturer, if you wait until the chamber wink light is completely black before attempting to open the door, everything should be good to go. And you can clearly see the gap between where that pin would extend in, so you can visually check that it has fully retracted before attempting to open the door. So a stuck chamber pin in this instance can happen in a couple different ways. Usually that's because there's some kind of a malfunction in this three-way valve. These things being mechanical, they can, after several thousand cycles, develop a hiccup or two. And just like what Deb and Mindy had demonstrated, these tubes can be pulled or cut in order to release pressure. Although with the Seacrest chamber, the first thing that they recommend is to attempt to push this pin mechanically back from the other side. Now, if the door was attempted to open prior to the pin being fully retracted, since it is a brass pin, when you rotate that cam, you can actually deform it in the chamber or inside the cylinder and make it much more difficult to push back. So do be aware of that. So we have a long wooden dowel here that is actually a clothing item that you see in retailers to set items on hangers up onto a second layer. But this works doubly well. 90% of the time we use this to slide our patient curtains back and forth on the rails because they get caught on the connections, and this very nicely hooks into that and drags it along. If it doesn't, with that gentle tap, open up, you can take a sand hammer or other rubberized item that doesn't have a lot of mass and tap on the end of this to help push that back out of the way if it was deformed. So that is the way in which the Seacrest chamber differs from the Perry slightly, in both the angle in which the pin extends and how much access you have to get it opened up into that. I was going to move into now taking these instances and how you make an interactive safety drill out of these kind of things. So using an interactive versus a desktop drill does a couple things. It is active. It gets you to get up, move around your department. They can actually be entertaining because you end up having to do things in front of other people while they're watching you, and invariably somebody's going to make a mistake that is hilarious, but also points out differences in practice that help to change your policies, and involves multiple elements of learning because of motor skills, verbal skills, and practical interaction between those. And then it ensures that what's written in your policy can actually be done, and that is the most important part of this versus a desktop drill, because our practice had always been to use an IV pen to push that port out. And long ago, when we had smaller chambers, the distance of that chamber that the pin extends into was small enough that an IV port plug could do that. But when in the process of rewriting this drill for doing it this year, we evaluated that our current 3600 chambers have a the pin port tunnel is so long that our IV pins wouldn't actually be able to push that back out because they're too short, and that's why we're switching to that dowel. And that's something that when you do an interactive drill, you find those things. Another very good example of this is when we would do our annual fire drill and we have to get to our evacuation point because our department is not anywhere near an exit. We've found a lot of trouble getting through all of the smoke and fire doors while you're trying to push a patient because they, of course, all close on the way between there and then. So it's important to practice these things so you can find out whether it is practically capable of being done. So when you are authoring a fire drill or any other safety drill, there are 4 types of drill that can be done. And this kind of follows Brenna's guidelines that he has, or Francois Berman's guidelines that he has in his book. I just call them a little bit different. So we have fire drills, we have medical drills, we have equipment drills, and then we have procedural drills. And the procedural drills are of a type that will vary greatly based on what your local health system has for its policies and procedures, how many personnel that you have in your department, what kinds of patients that you see, whether you'll see sicker patients, whether you see people on ventilators, or whether you only have walkie-talkie kind of patients that are all outpatient. If you have a mix of inpatient, outpatients, if you're multiplace, monoplace, and it can also vary on whether you are a contract facility within another health system, and like with NBS or Healogics, and you have to follow what their guidelines are in addition to what any local physical guidelines are for the building with which you're contained. There are 2 considerations when deciding what things you're going to make into a drill, and that's whether it's high risk, something that's highly likely to happen, as in the case of having a patient present with a low blood sugar, or whether it's something that is of high consequence, such as patient being stuck inside of a hyperbaric chamber until they asphyxiate, which would be the cause of this pin issue, or if it's likely to explode the chamber, or if it's going to cause a pneumothorax, or you might have something destructive to the physical facility, which is if you have an internal chamber fire and the thing then becomes structurally unstable. So the one drill that is very specifically spelled out is in the National Fire Protection codes for the United States, and that is NFPA 99. And it states in that the time required to evacuate all persons from a hyperbaric chamber with a full complement of chamber occupants and all at treatment pressure shall be measured annually. So they're saying that they want this tested at worst case scenario. If you pony up for the handbook that contains the comments, they explain that worst case scenario varies by what your physical facilities are and the type of patients that you see. So at my facility, we have 3 monoplace chambers. Our minimum staffing is 2 people, and I'll get into that in a minute. And and we have a mix of inpatients and outpatients. So when we practice drills, when we write the scenarios, we talk about how many patients are inpatient, how many are outpatient, how many people are at depth, whether they're at different depths, because we might have a carbon monoxide poisoning that's at our monoplace maximum depth, or we might have a bunch of people who are diabetic foot wounds we're treating at 2 ATA. We also have a changing area, and we have a procedure room, and we have a waiting room. So the scenarios talk about how many family are in, pre-COVID-19, how many family are waiting in the waiting room that we might also be responsible for rescuing out of our area, how many people might be in the procedure room, whether you have doctors around to assist with, versus just the staff, and whether there might be other responding departments. So if you're practicing something such as a code gray, then you may have, that's a security or disruptive patient in our facility, then you might have facilities people coming to your area to assist. Now, for a fire drill specifically, when you have a high risk, something that is likely to happen, then of those things, the most likely are prohibited items being attempted to brought into the chamber, things that patients don't think about being a problem, like thermohair heat patches, off-gassing from perfume or deodorants, and we often have to remind patients about that, particularly our female patients with perfume or younger patients with like Axe body spray. The high fuel source with certain dressings, and this is where your go no go list comes into effect, and then ignition sources like lighters, battery powered equipment, and whatnot. And the high risk for this is often the medical equipment that is battery powered, like your otoscope or your thermometer, being left on the cart when you go to place it inside the chamber. Now, these also, in the case of fire, also contain an element of high consequence, where you want to think about how you respond to fires in the chamber, fires outside of the chamber, and if it's outside the chamber, is it outside the chamber but in your department? Like a computer goes bad, and a lot of these portable documenting devices that we have their own batteries, usually they're lithium ion, and those have had their own issues. And then whether that fire then might impact critical infrastructure. So it's not in your department, it's in another area, but that fire in that area would impact your oxygen supply lines coming in from the liquid oxygen tank, or that it might impact your ventilation pipelines going out in your oxygen exhaust line, and whether it impacts any escape routes. Again, we're kind of tucked in a corner of the basement, so we have several areas to go through before we can get outside of the building. We have to keep track of when there's a fire drill, whether that's in an area that would alter where our rally point is going to be, or whether it alters our route to the rally point. And one thing definitely to practice is putting on your fire PPE to allow you to remain with the chamber without succumbing to fumes while you try to evacuate the patient out. So in the medical drills, your high risk items, the things that are statistically likely to happen more than something else, might be a seizure in the chamber, using different medications to help clear the ears, and knowing when it's safe to do that kind of thing in your anxiolytics. So if you have an inpatient who comes down, and can you give an IV push medication or oral medication without conflicting with everything else they've got going on? What kind of EKG changes can happen during a treatment? We at our facility do have EKG monitors, so we can watch that kind of thing. And it's very common for people to get more bradycardic than they were when they first went in, because of changes in the systemic vascular resistance that are oxygen related, and that affects cardiac output and stroke volume and heart rate. If they have a pacemaker, their pacemaker may think that something's up, and if they have an ICD, it may also think something is up. So you have to kind of know what the parameters are for those devices and how to react to that. We have had people come down who are post-flap, and it doesn't look real good even right away in the surgery, and so they'll send them down for us immediately out of PACU to post-anesthesia care unit to start treating them for compromised flap, and we have had one of those dehiss. So now we have to monitor what we do about that if it happens while they're in the chamber, because they can bleed quite a bit, and since they're cold post anesthesia, we were putting a sheet and a blanket in with them in our monoplace chamber, which delayed the time for us to notice that they were bleeding. And you have nausea, vomiting, diarrhea, so you have both that issue. If they have bleeding with that or without, either way, you still have you've contaminated your chamber. It's one thing if they're in a monoplace chamber with this, it's just kind of messy to clean up. But in a multi-place environment, you have other patients to consider, and they're also, in the case of nausea and vomiting, kind of trapped in with their hood. Of course, it's pretty common to have visual acuity changes, but keeping track of what might be the normal visual change, the myopic changes that would happen from just the pressure of the hyperbaric treatments versus what might be going on for someone who has glaucoma changes, or someone who has progressive advancement of their cataracts in relation to the oxygen exposure, is something else to keep track of. And then looking at when does somebody have anxiety versus getting into a pre-seizure episode, because people present anxiety in different ways. You have high consequence issues that can come up where you have a cardiac arrest in chamber, slightly less likely, but we do train for BLS and at our facility ACLS because it takes longer for people to figure out where we are. Pneumothorax and how to set up for that. Fortunately, do get a little bit of time to set up while you're decompressing the chamber. And then your visitor medical emergency and staff medical emergency, both of these you need to practice because you usually have limited staffing in a hyperbaric chamber. And if you have someone addressing a visitor medical emergency where they are pushing their loved one in and now they have symptomatic dyspnea or they have a acute myocardial infarction from that, how do you then address the rest of your department? And that makes a difference if you're in a hospital or you're in a separate clinical facilities, how you contact 911 or an internal response team for that. And if you have a staff medical emergency, you now not only have an additional patient to take care of, but you've lost one of your caregivers in the process. I'm sure all of you know that injury in the hyperbaric area is not an uncommon thing with staff because everything's made out of metal and there's pokey bits everywhere. So you getting bruised is one thing, but in a multi-place chamber, as has been demonstrated hilariously by Duke, you can walk your head into the steel of the chamber door and get injuries from that. So your equipment drills are things that we tend to interact with the chamber. What happens if a ventilator goes bad or it's not just delivering as you would expect it to be, or if a ventilator is not operating as you would expect it to. You may even have drills just to normally practice setting these up if it's not something that you do on a frequent basis. And then looking at things again on your go, no-go list for not just why they're there, what things are allowed, but what the reasoning behind it, so that people on your staff, when they look at that list, know whether that issue is generalizable or not. So we do allow negative pressure wound therapy dressings, but we disconnect them from the pump so that that battery electric pump isn't going in there. And we do allow snapback dressings as they are, because it's under vacuum. We just make sure that there's not an air space inside that cylinder before it goes into the chamber, but otherwise it should remain in equilibrium, just as a JP drain would if you fully compress it and remove the air before you put them in the chamber, so that that air does not shrink in volume as you compress the chamber and then increase the amount of vacuum. So in the appendix to the NFPA, it does say that with your, you should have a go, no-go list, and that the reason for that list should be kept on file somewhere so that it can be explained and understood. So as was explained in the presentation earlier, by Dr. Fong, we in our monoplace facility do allow the DESCOM continuous glucose monitors in, but not any others, for the reason that we have documentation supporting how those are manufactured and how they are tested, but we don't have that for any of the other devices. So your high consequence items are like loss of oxygen, loss of power, loss of water. This in a multi-place environment would have to be including of your deluge system if there was a failure of that for some reason. These happen often because of something not in your control. So your liquid oxygen tank is often outside the facility, but can be damaged by things like severe weather, by delivery trucks backing into it, or it can be damaged through a fire in an area not in your part of the building that your lines travel through. And if there's a loss of power, how do you, the hyperbaric chambers are pneumatically powered, but what do you do when you go on to battery backup? How do you compensate for the rest of that? Because there are certain things that happen with different chambers. With our particular chambers, the communication system continues to operate because that's on a 9-volt battery, but they wouldn't be able to continue to watch movies or any other distraction. So then you have to look at, what happens then if your patient freaks out with that and half the lights go out in the building, And then there are chamber malfunctions with the equipment, such as there have been some cases with chamber runaway compression and how you would stop and deal with that, or loss of the seal integrity. A lot of times you would sense this early in the compression phase because you start hearing a exaggerated leak and come to find out that a monitor cord or an IV line or string from a gown or something is laying in the door seal, and so you would hear that and then deal with that way. There are chamber exhaust port hazards, which I'll show you in a second, and then knowing how to work your fire extinguishers that you have in your department, how to work your fire alarm pulls, which can be of different designs depending on the facility that you're in, and some of them can be harder to operate than you might think. So this up here is our chamber exhaust port. It's on the roof of the building, goes up through 3 stories of building to get to the roof. And we have our sign here that says it's oxygen warning. This is actually from 2 days ago when we got a late storm of snow, but our security camera lets us monitor that to make sure that we're not getting any obstructions. So if you've been closed for the weekend, as a lot of outpatient facilities are, and you come back on Monday and suddenly you find you have wasps all over the place in your camera view, and then you get to wondering, well, darn, are they building nests in our mesh down here? You have to think of, what is your process for going through and ensuring that your equipment is okay, and how would you know that maybe it wasn't? Because you might have construction debris that has blown over the top of your ports that can alter the outflow and might make this particular item more flammable, or you might have contractors who are washing the windows and happen to be smoking up there because they don't think anybody can notice. So your procedure drills then are of a type, again, that varies highly by where you are, but are definitely needing to be practiced because severe weather happens every year. You're going to have tornado drills, you're going to have snow warnings, you're going to have thunder, lightning, whatever, ice storms, depending on where you are, potentially flooding if you're prone to that. So you need to discuss, exactly how you operate calmly for those and what you do during that environment. Disinfection protocols are becoming more important to practice. So if you get a patient down with C. diff or multi-drug resistant antibiotic or bacteria of some kind, how exactly you're going to clean out all your equipment. A little bit, in this instance, easier to do in a monoplace environment because you just have the tube and the cart and the mattress. but then, you know, things that get aerosolized, you know, how are we, this is all still kind of evolving with the COVID-19 about how to get everything cleaned properly without damaging the equipment. UHMS has some new standards that have been published on this and are evolving, you know, almost by the week, but that's a good source to look for that. And then different codes that you have, like if there's a code pink, which is an infant child abduction, we're a hospital-based facility, so we are supposed to respond to that, but we do have a staffing minimum. So how do you set someone out in the hallway and then not taking care of patients that are in the pressure chamber at depth? And, you know, can you or can you not respond to that, and how you do that? Again, code grays are ones we've talked about where you have a security risk with a disruptive family member, and how do you, when do you activate it? When does it rise to that level? And then what can you expect to happen once you do call it? And then when you start something new, so when we started our safety timeout and pause checklist, we created a procedural drill to initiate that new thing, because it was going to be very common and was new, and we wanted to make sure that everyone was doing it correctly. Your high consequence things are, you know, active shooter bomb threats, and the I can tell you that we did have a bomb threat at our facility at one time, and I was very shocked because we'd never really practiced that before, about what happens once you call one of those. And you get a whole bunch of people with uniforms and firearms who show up, and then you also get some fire department people who show up, and all of them stand outside and then direct you to go in and tell them what might or might not be different, which was not what I was expecting to have happen. And then the another high consequence thing to practice is what happens when you have somebody who's unreasonable, who tries to sneak something in, and how you would respond to that. So when you create a meaningful scenario, you know, okay, so these are different environments that are happening, and almost all of those things that I listed in one way or another did actually happen or almost happen. And so when you get a mistake, it's they talk about it as being a Swiss cheese event, where multiple holes of multiple slices of cheese have to line up for something to fall all the way through. And you can have a tendency to stick to your critical errors on looking at the things that actually reach the patient and actually cause harm. But really, you should look at the things that were good catches and near misses as well, so that when your other staff who weren't there that day, or maybe newer, or didn't understand the circumstances, they don't have a chance to learn from that if you don't then turn those into drills that you can then practice and discuss with others. And there may be different situations that you can then talk about, or different solutions you can talk about. We have one, we're starting to put these safety drills as seed ideas up there onto the Baramedical Nurses Association website. And if you go to the main landing page and click on safety, and then click on safety drills, the first thing that we have is emergency procedure type of drill, which is an active shooter or violent intruder. Now, again, this is a seed idea, so there's a lot of it in the interventions and discussion part of the drill that you would need to personalize for your facility and your environment. But the intent of these drills is to give you a feeder that you can then use for your facility. So the drill format starts with the scenario, which is what is going on and who is present. So again, the best situation is train your worst case environment. So this sometimes means all of your staff, all of your providers, and you have lots of patients and visitors around. And sometimes for the purpose of the drill, it might be important to say that you're at your minimum staffing and that you don't have a lot of patients around. So if you're practicing for a staff injury, what happens when you're already at your staff minimum, which in some facilities is, some monoplace might be 1 CHT. What happens if your 1 CHT has trips and falls, or slips on something wet, or some juice on the floor, hits their head on the chamber, and now they're unconscious? Now what happens? So look at those with that light. The next thing to have would be a section of critical steps. And these in our formats are just a Roman numeral list of steps that are supposed to happen. And they're in the sequence that they're supposed to happen. There's a initial response, which might be airway, breathing, circulation. It's your limb saving things, activating your fire alarm, activating your code blue system, something along those lines. And your secondary response with your interventions after that are usually particular for that type of drill. And your tertiary response is whatever's left, often relating to documentation that you have to do for that type of drill. And then we follow that with a text section that kind of explains everything. So in the case that we're talking about today with the locked pin, what happened, we've had this happen in two situations. One was with our older chambers, and there was a different time delay between when the wink light went out and when the pin would retract. And if you had somebody at a really low flow rate setting, there might be a really long time before that pin actually retracted. One of the staff members attempted to open the door and it trapped the pin inside of that tunnel. And so then this drill was created to make sure everybody understood how to quickly resolve that situation. The other time that this happened is there was a fault with that three-way valve. And fortunately, in that instance, the fault is that the pin wouldn't extend in. And so we just had to make sure that we're careful with, if that happens, does the chamber still operate properly? And what do you do when that safety feature is then no longer there? But in this case, we have a staff member and the pressure reading is at 0 and the chamber's still black and the door is pinned. Now what do? So at this point, we pause in the drill, the person who's directing the drill, and they have people act out what they would do. And they're saying what they do and then actually go and do it. They have to know where is that wooden rod so that they can put it in. Where are the scissors so they can cut that tube if they need to? Because it's important that everybody knows where to get the item is when they need it. The person running the drill is actually looking down the Roman numeral list and looking to see that did they turn the chamber back on? Because when you turn the chamber off, most monoplace chambers have a safety feature that keeps some oxygen flowing through the chamber so they don't asphyxiate. It also controls the temperature so it doesn't get hot and stuffy, which would contribute to confinement anxiety. So the first thing you want to do is turn the chamber back on, and then inform the patient there's a delay if they are, otherwise used to the chamber being open right away, and then have the coworker gather supplies if you have one so you can reassure the patient and make sure they don't feel like they're just stuck in there. Then when you have everything together, you turn the chamber back off and push the pin back out of the way with a wooden dowel, a capped Sharpie, something that's a larger diameter. You do have to be careful that if you use too small of an item, you can further deform the pin because it is brass. And if you're using force to push it back, that can cause more problems. Or you could stack some IV plugs together if yours are too short, as ours turned out to be. Remove the patient from the chamber and then look for any residual effects. And then the tertiary response would be completing an event report, and then taking the chamber out of operation until cleared, in our case, by Seacrest, clinical engineering, safety officer, and medical director, because we're in a hospital, so we have to add this other layer into the equation. So when you get to the text section, your background for that is then discussing why you're talking about this. So you may talk about, in this instance, the things that have really happened, or why research that's led, or a news article that's said what's happening and what's going to go on, why you're bringing this drill into existence. And then the issue is this section for us talks about why each of those steps that you had before are listed as they are and what's the reasoning behind them. And then when you come down to the closing section, this gives you kind of your bullet point summary so that if you have these printed or you have these saved somewhere or you have new staff coming in, then they can often place what you'll see is they will flip through the book and they'll be reading the closing summaries, and then that draws them to read through the rest of the drill if it's not one that they were had participated in yet or at the time. The big thing to remember is when you're doing these and you're reading the scenario part, don't be like Alex Trebek and act like you have all the answers, and definitely be open and observant for what the staff are doing as they go through and do it, to make sure that they're doing the steps in the order that you have and that the order makes sense, because this is an opportunity to see where your response is either not practical or that there might be some issues like creating a safety kit, as Deb and Mindy have done, so that you have the items in a readily accessible point and that everything is available when you need it at the time you need it. And that you have the personnel trained in what to do with the item once they have it in their hand. So the end point of this is to make sure that you have everything prepared, practiced, and well arranged, so that when you get to the end of your drill, you don't, and something actually happens, you don't end up tying yourself up in a pretzel trying to react at the point of time and then not knowing where everything is and what items are available.